Hello and welcome to today's webinar titled Discussing Options and Referring Adolescents to Treatment. I'm Tracy McPherson and I'm going to be your moderator for today's event. If you have any questions about today's webinar or any of the webinars in our series, you're welcome to contact me at the email address shown on your screen, mcpherson-tracy@norc.org. Today's webinar is produced in partnership with the Adolescent SBIRT Project, NORC at the University of Chicago, and the BIG Initiative, and it's sponsored by the Conrad N. Helton Foundation. You're welcome to contact us and learn more about our work at sbirt.webs.com or contact our SBIRT team at sbirtteam@norc.org. Today's webinar is one of a series on using SBIRT to talk to adolescents about substance use. So we hope that you will check out all of these important topics. And in addition to today's webinar on discussing options for referring adolescents to treatment, we have several other webinars that we hope you'll take advantage of. One focused on substance use screening tools for adolescents, and another one focused on brief intervention for adolescents, which is in two parts. Part one is focused on brief negotiated interview, or BNI, using motivational interviewing strategies, what we call MI strategies. And then we have a second part, which is an expansion of brief negotiated interview using MI and cognitive behavioral therapy strategies. You can learn more about all of the webinars, how to register, and learn about how to download a flyer that you can share with others at sbirt.webs.com/webinars. If you're following along today with the Learner's Guide to Adolescent SBIRT, the education we're going to be sharing with you today is information that complements Module 4 on referral to treatment and follow-up. You can learn more about the Learner's Guide. You can also request an electronic copy or find an order form for a hard copy on our website at sbirt.webs.com/curriculum. For your future reference, you can download the PowerPoint slides and other resources on our website at sbirt.webs.com/referring-adolescents. After today's webinar, you are going to receive a follow-up email from us, and that contains instructions for watching the on-demand recording, obtaining a free certificate of attendance, and completing a short evaluation survey. Now, we would greatly appreciate you completing this survey. It's very brief, but our aim really is to provide you with high-quality professional education, and this survey helps us to assess how we're doing and also to better understand your needs. If you wish to ask questions, you can do so by typing into the questions pane into the GoToWebinar control panel on either your computer or your mobile device, and someone from our staff will respond to you as soon as possible after the webinar concludes. Now, it's my pleasure to introduce our presenter today, Dr. Ken Winters. And Dr. Winters is a senior scientist at the Oregon Research Institute and adjunct faculty in the Department of Psychology at the University of Minnesota, which is where he retired from as a professor in the Department of Psychiatry, and where he founded and directed the Center for Adolescent Substance Abuse Research for 25 years. Dr. Winters has received numerous research grants from the National Institutes of Health and various foundations, and has published over 125 peer-reviewed articles over a 30-year period. He recently co-edited the second edition of the Clinical Manual of Adolescent Addictive Disorders, which is published by the American Psychiatric Association. Dr. Winters also serves on editorial boards of the Journal of Substance Abuse Treatment, Journal of Child and Adolescent Substance Abuse and the Psychology of Addictive Behaviors. And Dr. Winters received his BA from the University of Minnesota and a PhD in clinical psychology from the State University of New York at Stony Brook. So it's my pleasure to welcome you, Dr. Winters, and we appreciate you sharing your expertise with us today, and I'm going to turn it over to you.
Thank you much. Welcome, everybody. It's a pleasure to have this opportunity to be a presenter of this webinar. I want to give a big thanks to Tracy and Misty for their work in organizing and helping with this training event. Let's begin by talking about general issues pertaining to referring adolescents for treatment of a substance use problem. A small percentage of adolescents will require a level or intensity of treatment beyond that of which the practitioner may be able to provide from a brief intervention. Such adolescents then may be referred to a specialty treatment facility that offers residential and/or outpatient treatment programs. What do the numbers say? A data set from 2016 called the Treatment Episodes Data Set reports that about 78,000 adolescents in the teenage years of 12 to 17 were admitted to some type of treatment center a couple years earlier. So many thousands of teenagers are getting referred for specialty treatment. Here is a chart that shows a breakdown of referral sources. Of those admitted to treatment, 44% were referred from court or criminal justice systems. But what's interesting here is nearly 20% of admissions were self-referred. This percentage underscores the importance of a brief intervention, which encourages youth to take positive actions around their substance use. By using the SBIRT model, adolescents in need of treatment can be identified and gain information, hopefully see the advantages of behavior change, and in some instances, gain insights that more treatment may be needed. Unless under a court-ordered mandate, the adolescent must be agreeable to participate in treatment. How the practitioner broaches and discusses referral contributes to the likelihood of a successful treatment referral. In contrast to adults, adolescents, for the most part, are less likely to feel that they need help or seek treatment on their own. Developmentally, adolescents have a harder time recognizing their own behavior patterns than adults. Adolescents have shorter histories of substance use and therefore are unlikely to have experienced as many adverse consequences from their substance use compared to adult users. Fewer adverse consequences can mean less of an incentive to change or to engage in any type of intervention or treatment. Engaging adolescents in a clinical setting requires patience, as well as an open and empathetic therapeutic stance. Whereas these are important facilitator skills when working with all clients, the challenges of building rapport with an adolescent client are such that patience is a most vital principle. There are several considerations with respect to the involvement of parents in the treatment referral process. Depending on the age of the adolescent, the degree of acute risk, and state regulations regarding access to health care by a minor, it may be necessary to involve the parents or guardians of the adolescent, regardless of whether or not the adolescent consents. Breaking confidentiality in this situation can be challenging. Therefore, it's important to be familiar with legal issues associated with maintaining or not maintaining confidentiality, a topic we will discuss more of later in this presentation. Some additional contextual factors. Reluctance and resistance to change are characteristic of adolescents who may have a substance use disorder. Thus, she or he may be unwilling to pursue treatment. And for various reasons, parents may also be reluctant to have their son or daughter seek specialized treatment. It is important for the practitioner to be supportive during conversations with the adolescent and parents about the adolescent's care options. Motivational interviewing strategies can be used to encourage both parties to accept a referral. More details about motivational interviewing can be found in webinar 3 of this series. But now let's review 4 keys when dealing with possible resistance to a recommendation for a referral for treatment. First, encourage parents to have an honest, open discussion with a teenager. Second, it's important to avoid deception and any false promises. A third key when working with parents is to guide him or her to use motivational interviewing skills, the kind of skills that hopefully you've been using with the teenager. Keep in mind, the parent can have a major influence in getting the adolescent to agree to services. A helpful strategy for the parent is to use the pros and cons exercise, something that really is a skill all can learn. And with that exercise, emphasize the benefits of getting professional help. But it's important for the parent to have the teenager talk about the negatives, or perhaps their fears or concerns about seeking help. A fourth key, consider offering your services as the practitioner to discuss the situation with the adolescent. And in such a situation, you will want to use the pros and cons exercise also for this discussion. More on these strategies that you can implement later in today's webinar. So why is it important to refer an adolescent to treatment that needs it? There is the obvious value of supporting the health and well-being of the adolescent. As noted by the National Institute on Drug Abuse, adolescents can benefit from some type of substance use intervention even when they're not revealing a substance use disorder at a serious level. Any amount of substance use is concerning for young people due to the increased risk to several consequences, such as motor vehicle accidents, unwanted pregnancy, poor school performance, depression, and if the use accelerates, the potential for developing dependence or a severe version of a substance use disorder. Another consideration regarding the importance of connecting a substance-using adolescent to treatment is that on average, the longer a duration between the first substance use problem that emerges and by the time the person gets treatment, when that interval is long, it means the person is going to have a tougher time achieving a stable, drug-free period. So when you can reduce the interval between the time of the problem first emerges and the person gets treatment, if you can make that as short as possible, you're likely increasing the likelihood that downstream that person will have a good recovery. Next up, more details about the referral process. Referrals or handoffs for a level or intensity of treatment beyond that of which the practitioner can provide are challenging in virtually any endeavor. Perhaps this is the case that is more challenging with adolescents. particularly if he or she does not think there is a substance use problem. David Gustafson has studied the characteristics of handoffs in activities as diverse as daycare drop-off and pickup, surgery, air traffic control, relay races, 9/11 calls, even professional football. These studies found that all situations require a smooth handoff, and a failed one disrupts service delivery and introduces errors, sometimes with negative consequences. Data on referral patterns for adolescents is lacking in the literature. However, recent national data provide information on referral sources for adolescents entering substance abuse treatment. Let's go back to the TEDS data, the treatment episode data set. A 2004 data set of adult populations, those aged 18 and older, only 16% of those discharged from a detoxification program received a new level of care. If we go to residential programs, only 30% received an additional level of care. And only 50% of those who started outpatient completed their regimen. So it is likely that far too many adolescent clients are also lost in the system during handoffs from one level of care to another. Gustafson suggests 8 principles that, if followed, can dramatically improve the transition of clients with a substance disorder between levels of care. Keep in mind that these principles, when applied to adolescents, likely require that both the adolescent and parent mutually agree to the referral decision. So let's go through all 8. First one, commitment. The practitioner who makes referrals must believe that handoffs are essential for the adolescent and for the organization as a whole. The practitioner plays a critical role in successful handoffs, but this commitment must be felt throughout the entire process. Second one, responsibility. It's not a news bulletin. Many adolescents do not follow instructions from a medical doctor and may not follow yours either. But it is your responsibility as a practitioner to ensure that adolescents with complicated chronic problems, such as a substance use disorder, receive a transfer to the appropriate care. Noncompliance is the reason we should devote more attention to successful handoffs. The third, from Gustafson's list, understanding the client. Keep in mind we are not handing off an inanimate object, such as a football. We must respect and incorporate both the unique needs and circumstances of adolescents in managing the referral. Number 4, designation and clearly defined roles. This principle talks about the need for a successful handoff, making sure that responsibilities of the individual giving the adolescent the next level of care and the person receiving the adolescent, all of those responsibilities are clearly defined. In a smooth handoff, the receiver, the referral agency, is fully informed of the adolescent and demonstrates that they understand what the adolescent has experienced and what responsibilities they have in taking on the case. The fifth is presence. The notion here is adolescents are not sent but are delivered. They could be viewed in the same way as unaccompanied minors are viewed in the airline industry. They need to be handed off by one supervising airline employee to another when boarding, making a connection and arriving at the final destination. all involves active participation. The sixth one, common language for handoffs. Gustafson talks about a common language being crucial to activating any successful handoff process. Organizations in virtually every field have specific, highly clarified language that so-called all participants and players understand. Make sure that is the case when you're working with the referral agency that's taking the handoff. The last two. Number 7, practice. A smooth handoff is standardized, synchronized, and practiced over and over again. Every field that performs good handoffs engages in a lot of practice to make them happen. Handoffs can be hard to practice in a setting where they've been done infrequently. So that's the challenge, I think, for many of us. All practitioners who encounter these types of referrals on a frequent or infrequent basis are encouraged to keep abreast of the changes in providers and treatment services in your area so that you have a current set of information when the need arises. The last, monitoring, evaluation, and improvement. In sports, team members are constantly graded on how well they're playing their roles, and they retain or lose their spots in the lineup based on performance. Grading also identifies areas where teaching can improve performance. The point is, many systems have ongoing monitoring and evaluation programs, and when integrating SBIRT into practice, as best as you can, with whatever resources you have, try to monitor the success of your handoffs. Look to see how, when you're sending a youth from one level of care to another, how well it's working. And with that information, hopefully you can make necessary adjustments and improve the process. Now we turn to a discussion of when a referral for treatment or other type of clinical service is advisable based on the SBIRT model. There are 3 factors to consider. Number 1, the teenager's score on the screening tool. When that is very elevated and suggests a high risk status of the person, it might be the case that a brief intervention is bypassed because the person really needs more than what a brief intervention can provide. Second factor or reason, there is no progress during the brief intervention. And it looks like the teenager really does need more services. And the third, during the brief intervention, you may discover other health issues such as co-occurring disorders. And you realize that those other problems and areas need more clinical attention. Some attention now on the issue of coexisting problems and co-occurring disorders. I'm sure most of you realize that when you work with an adolescent with a substance use disorder, it is common for him or her to have at least one other co-occurring disorder. The most common ones that coexist with substance abuse are conduct disorder, oppositional defiant disorder, ADHD, depressive disorders, anxiety disorders, and PTSD and trauma. Whereas the field has made some progress in getting treatment for youth that have both a substance use disorder and a co-occurring disorder, it is probably the case that still many youth with a substance use disorder do not get adequate treatment for their co-occurring problem. And it's probably also the case that many with a mental disorder do not get treatment for a possible underlying substance use problem. What about the intersection of substance use and problems that do not necessarily meet diagnostic criteria? On this slide, you can see how the number of problems an adolescent experiences is a function of the number of substance use disorder symptoms. For example, look to the bar to the far right. That group of adolescents has the most substance use disorder symptoms, and they also report many more problems, basically in the category of psychosocial problems, than adolescents who have fewer substance use disorder symptoms. So the far right bar shows you where the biggest problems are loading, and as you cast your eyes to the left of that, and you see how there are fewer symptoms associated with fewer other problems. So even with a teenager that isn't meeting diagnostic criteria for a co-occurring disorder, if you're talking about a youngster who is abusing substances, there's probably many other issues going on with him or her. And many of these are likely going to require clinical attention. Back to discussing treatment options. The American Society of Addiction Medicine, or ASAM, suggests the following dimensions to determine the appropriate intensity and length of treatment for adolescents with a substance use disorder. The various dimensions are the following: level of intoxication and potential for withdrawal, presence of other medical conditions, presence of other emotional, behavioral, or cognitive conditions, readiness or motivation to change, risk of relapse or continued drug use, and the recovery environment of the youngster. The ASAM system uses these dimensions and then provides guidelines as to how you can determine the most suitable level of treatment for a teenager, ranging from short-term detoxification to the most intensive treatment, long-term residential care. What are the most common treatment settings in which adolescent substance use treatment occurs? I think there are three that we will discuss in some detail. Nowadays, the most common is outpatient or intensive outpatient treatment. This can be highly effective and is traditionally recommended for adolescents with a less severe substance use disorder, and also report fewer additional mental health problems and have a supportive living environment. Although some studies have demonstrated that more severe cases can be treated in intensive outpatient settings as well. Then there's the setting called partial residential. This model is indicated for adolescents with a severe substance use disorder, but also who can be safely managed in their home living environment. A typical partial residential program has adolescents participate in 4 to 6 hours of treatment per day, at least 5 days a week, but they're still living at home. Then there's residential and inpatient treatment. This setting is suggested for adolescents with severe levels of substance use disorder, mental health issues, perhaps medical needs, which may require 24 hours, and they're not living in an environment that is stable. Treatment in a residential setting can last from 1 month to 1 year, although it's a lot more common these days for these settings to only last about 1 month. For the next few slides, I will review the major treatment approaches, not settings, but now we'll talk about approaches to treat adolescents with a substance use disorder. First up, behavioral approaches. Research supports the effectiveness of various behavioral-based substance use treatment approaches for adolescents. One or more of the options listed below could form a reasonable action plan. It's my read of the literature and my view of talking to many practitioners in treatment programs that most programs use an eclectic approach and employ various behavioral-based therapeutic models. But the main ones are the following: adolescent community reinforcement approach, cognitive behavior therapy, contingency management, motivational enhancement therapy, and 12-step facilitation therapy. Not exactly the same as 12-step, but there's a version that is called the 12-step facilitation approach. All of the above, to a lesser or greater degree, use behavioral-based strategies. Next major approach are the family-based treatments. These approaches seek to strengthen family relationships through improving communication and developing family members' ability to support abstinence from substance use. Involving the family is viewed by most experts in the field as very important, even necessary in some people's minds, when treating adolescents with a substance use disorder. Is there a case to be made if a family is so dysfunctional that the counselor should withhold or postpone including the parent as part of treatment? It's a good question. My read of what experts say about this issue is that in some cases the answer is yes. This judgment call is part of the skill of being an effective family therapist. The major family-based approaches include these: brief strategic family therapy, family behavior therapy, functional family therapy, multidimensional family therapy, and multisystemic therapy. Next, medication-assisted treatment. Medications have been shown to be effective in treating disorders specific to opioids, alcohol, and nicotine with adults. But the situation with youth is not clear-cut. Whereas there is some preliminary evidence indicating the effectiveness and safety of addiction-related medications for youth below the age of 18, only one medication related to addiction has been approved by the FDA. That's buprenorphine, and it's approved for use with adolescents age 16 and older to treat opioid addiction. Another category of treatment is the topic of continuing care, which occurs after formal treatment is complete, or at least the initial treatment experience is complete. Recovery support services aim to improve quality of life and reinforce progress made in treatment. Examples include assertive continuing care, mutual support groups, peer recovery support services, and recovery high school. There are several publications that provide summaries of adolescent drug treatment literature. The first two noted here are peer-reviewed publications in journals. These are accessible using Google Scholar. The third is a book chapter. And the final one is a very helpful one from the National Institute on Drug Abuse. It provides a nice summary of the key elements of effective adolescent treatment. There are 13 of them. And this report can be downloaded for free at the website you see there. Here is our first audience polling question. So please select your answer on your device, and we will talk about it in a minute. We'll give you time to answer. So here's the question. Do you feel comfortable referring an adolescent with a substance use disorder to a residential-based treatment program? Please choose one of the three. Yes, no, I am not sure. So we'll give you a little time here. Okay, results are coming up. Interesting, I think. Only 9% said they did not feel comfortable. 61% said yes, comfortable. And then there's the 30% not sure. Of course, there's a lot of reasons for not sure. It might be because you're not all that up to speed or knowledgeable or aware of what kind of residential-based treatment options are available. Got a related question. We're going to do a second poll right now. If you need to refer an adolescent with a substance use disorder, does your community have a residential-based treatment program? 3 answers. Select one. Yes, no, I am not sure. Give you a moment. Okay, distribution of answers. 45% said yes, 33% said no, and 22% said not sure. One reason I asked this question is because of my awareness of the perhaps unfortunate trend that there are just less publicly funded residential-based treatment options for adolescents with a substance use disorder in recent years compared to years back. Even 5 years ago, 10 years ago, there were a lot more options. It's somewhat encouraging that almost half of you feel like there is an option, presumably local and nearby. I'm hoping the trend doesn't go in the wrong direction where we get less and less publicly funded options. What happens is then the private industry moves in, and it's very expensive, and that it can create many more financial barriers than are tolerable. Okay, next is a focus on the conversation about a possible referral. When discussing referral options with the adolescent, set the tone by displaying a non-judgmental demeanor and explain the practitioner's role and concern. Also, connect the screening results, the conversation from the brief intervention, and the basis for the current visit to the need for specialized treatment. For example, you might say, "We have talked a bit about your struggles at home, at school, and with your health. And I think some changes around alcohol could help with the issues you identified. Your score of 4 on the screening tool indicates that you might benefit from some help with cutting back on drinking. Working on this through outpatient counseling with a counselor or other health professional might be helpful. What do you think of the idea?" Here's another possible way to start the conversation with an adolescent. I'm glad that you want to make significant changes in your health by decreasing the amount of nicotine and marijuana you vape. You know, adolescents in your situation are often more successful if they also see a counselor who specializes in this topic. We have some excellent programs in our area that might have helped many people in the past, and they might help you with your situation. Would you be willing to see one of these counselors to assist with your plan of recovery? Another example. Your score of 6 on our screening tool indicates that you are at great risk of developing opioid dependence. I'm very concerned for you and your health. I understand your desire to want to cut back on your own, and I applaud your determination. However, your heavy use of opioids can be dangerous, and you might have problems with opioid withdrawal also. A good way forward is for you to think about a residential program that can safely manage your possible withdrawal and help you deal with your dependence. I would be really worried if you were to just stop going cold turkey on your own without the care of a health professional. That could be dangerous to your health. Last, another example. We've talked about the impact that the use of Xanax has had at school and playing sports. And I think some changes around your use could help with the issues you've identified. Your screening score indicates that you might benefit from some help reducing your use. Working on this with a counselor or a nurse like myself could really be helpful. What do you think of the idea? There are several other considerations to think about with respect to the referral process. Here we turn to the issue of confidentiality. Information that is protected by the federal confidentiality regulations can be disclosed after the adolescent has signed a proper consent form. Some states require parental consent for a minor to receive substance use and/or mental health services. State regulations also permit disclosure without the adolescent's consent in situations such as medical emergencies, child abuse reports, program evaluations, and communications among staff. Any disclosure made with written client consent must be accompanied by a written statement that the information disclosed is protected by federal law and that the person receiving the information cannot make any further disclosures of such information unless permitted by the regulations. Another issue is determining the most appropriate referral source or sources. Of course, every adolescent is different and has varying needs when obtaining assistance. Practitioners need to consider the many multicultural factors that impact the treatment process, such as race, gender, religion, spirituality, primary language spoken, as well as geographical constraints and financial factors. Become acquainted with the available community options for teenagers, including mental health services, because for some communities, specialized drug treatment may not be available. Also important are education and prevention programs for youth in the early stage of substance use. It is optimal if you can evaluate and, whenever possible, remove or minimize potential barriers to successful engagement with the helping resource. Potential barriers can include lack of access to childcare, lack of financial resources, transportation issues, legal complications, and medical needs. Identifying and addressing these barriers can help ensure the client access the assistance or treatment resource available to her or him. Then there is the importance of explaining to the client in clear and specific language the necessity for and the process of referral. Doing so will increase the likelihood that the adolescent will understand what's going on and hopefully comply with the referral recommendations. It cannot be said enough of the importance of the practitioner taking an active role in arranging a referral to an appropriate service or resource. It is preferable for the referral to be arranged immediately using a warm transfer or handoff, where the practitioner connects the adolescent directly with the treatment provider by telephone while the adolescent is still in the office. However, if impossible, the practitioner should then try to contact the adolescent within 24 hours to arrange a referral. Let's carry this theme a little further. Does immediacy matter? Yes, it looks like it does. The speed at which you can link an adolescent to treatment dramatically impacts their likelihood to show up, remain in treatment, and experience positive outcomes. Offering a treatment appointment date immediately and reminding the adolescent of their initial scheduled appointment usually improves the rate at which adolescents will begin treatment. The first 24 hours after you and the adolescent agree on a referral plan is a critical period for success in the adolescent eventually accessing that stepped-up treatment option. This short interval may not be realistic in many instances, but research shows that if the gap between your discussion with a teenager and the first appointment for a different level of care is more than 2 weeks, failure for the referral to occur is virtually certain. Of course, there's waiting lists on so many programs, and it's discouraging to see that if waiting lists are 14 days, even though you've done all your good work, can negatively impact whether the referral occurs. But many programs know that, and they're not letting the waiting list be a barrier, and they're doing their version of informal contacts and brief contacts to keep the adolescent connected, so that there isn't a large gap between when a recommendation was made and when the first appointment occurs. If you are interested in additional resources about recovery models and services, here are several. The first two websites pertain to recovery type schools. One is the Recovery High School resource. The other is about recovery colleges or colleges that have recovery programs. The third is SAMHSA's Guide to Peer Recovery Support Services. If you're interested in mutual support groups or self-help groups that are adolescent friendly, smartrecovery.org/teens is a good site. And then there's HBO's Addiction, Drug Treatment for Adolescents, a documentary they produced several years ago. This slide offers websites for locating treatment services and specialists. Sources include SAMHSA's 3 locator sites, as well as sites from the American Society of Addiction Medicine, American Academy of Addiction Psychiatry, and the American Academy of Child and Adolescent Psychiatry. Checking your local state Department of Human Services and websites they offer also is very advisable. Next up, how to use motivational interviewing skills to facilitate the referral process. These skills are discussed in great detail in Webinar 3 of this series. For the next few slides, I will highlight some key points. For adolescents who express little motivation to go into more intensive treatment, the primary task is to engage him or her in a discussion that allows the practitioner to get a good understanding of how their view of substance use may influence their decision not to choose treatment. When adolescents hear themselves describe their thoughts and feelings about their substance use to a non-judgmental listener, they may be more likely to understand their mixed feelings, which can serve to increase their level of motivation for treatment. The practitioner can facilitate this process by asking open-ended questions, making empathetic reflections, and using summary statements. The following is an example that shows how these strategies can be used together. So you're saying that you know that your opioid use is bringing you down and messing up your relationships with your family. But you are apathetic and feel like, well, what is counseling going to do for me? But you think it's possible that it's partly the use itself that's got you feeling that way. But you just don't feel ready to commit to treatment yet. Is that what you're saying? After the practitioner makes reflective listening statement that expresses an understanding of why the adolescent does not want to go to treatment, then you can move on to the next steps. You might ask the adolescent, what would need to happen to raise her or his level of motivation? If the initial response is something vague or non-committal, like, I don't know, try something like this. It's hard to know what could happen that could make you feel more motivated for counseling. Sometimes people get more motivated because some things in their life get worse, like health problems or getting poor grades in school. Sometimes people get more motivated to go into counseling because something good happens that makes it easier for them. Like they find out that they can get transportation or that their parents or friends are supportive. Do you relate to any of these? If the adolescent is willing at this point to consider options for treatment or related clinical services, the practitioner could move to the discussion of barriers. For example, if the adolescent is not willing, the practitioner might close the discussion with a summary statement that conveys that the option is open for more intensive treatment in the future. For example, you're saying that you know that counseling can help people and has been helpful to you, but you just don't want to go back to it at this time in your life. You just don't feel ready to give up using at this time. You feel like you'll know when you're ready and you'll know to get treatment then. Did I get that right? Now, you may have an adolescent who expresses moderate motivation to go into more intensive treatment. Here, the primary task is to express understanding of their ambivalence and elicit change talk that will tip the balance in favor of the adolescent being more committed to agreeing to treatment. This can be done by exploring ambivalence, expressing empathy, and reflecting. For example, a practitioner might say the following. Tell me about some of the reasons why you would be motivated to get counseling. What would need to be different for you to go to counseling? Tell me about some of the reasons why you would not be motivated to get counseling. All good, open-ended questions that hopefully can get a discussion going. Use reflection to express empathy toward the adolescent's responses. For example, so you're saying that you want to go to treatment because you're sick of being tired and grouchy. You really sound tired of that life and those feelings. Or this, I see the way you light up when you talk about how you'd like to get treatment and be a better friend. It's likely you will experience more success by accepting the fact that the adolescent is ambivalent and that sometimes they may not feel like acknowledging the potential benefits of treatment. Always remain patient and express empathy. Double-sided reflections that include both sides of the adolescent's ambivalence show that you are understanding him or her. For example, so what I'm hearing is that you don't really feel like getting counseling now because of how much work it is, even though you think it would make things better for you and your family. Also, you can ask questions that invite the adolescent to describe the potential benefits of treatment. How do you think it would affect your life if you got counseling? Or, sounds like you feel that going to treatment could help your health. Tell me more about what causes you to say that. Then you might have an adolescent who is expressing high motivation, but avoid trying to convince him or her that they are making a good choice, because doing so too rigorously could run the risk of raising pushback in someone already motivated. Instead, it's best to allow the adolescent to explain the reasons for that motivation. Sample can be, you indicated quite a bit of motivation to get treatment for your substance use right now. Or, is that also related to why you want to get treatment? How so? If you are getting signs that the adolescent is very motivated to seek treatment, you still can explore possible ambivalence. This is helpful because it allows the adolescent to know that it's okay to talk about their reservations. The reason to discuss ambivalence is to decrease the likelihood that these reservations will result in not following through. You might approach this by saying the following. You're describing a lot of reasons why it would be a good idea for you to get counseling for your Adderall. Sometimes, even when someone is really motivated to get treatment, they might have some negative feelings or concerns about that. How do you feel about it? Always important to support change talk. This can be done by expressing recognition and appreciation that the adolescent is committing to doing something that is not easy, is a positive step to improve her or his life, and is taking that step willingly and openly. For example, you might say this. I appreciate that you have been so open in looking at the ways marijuana has been complicating things for you. Now you're planning to take back control of your life by going to treatment. That's a really positive step you're taking, and I know it is not easy. Okay, let's give this a try with a role play. I will be the practitioner, and Tracy's going to join us, and she will be the adolescent girl. So here is the setting. This girl is an 18-year-old college student and is visiting the college health center because she is mandated to see a counselor after getting caught drinking in her dorm room by the resident assistant. The practitioner conducted a screening using questions from the CRAFT plus N 2.1 and the PHQ-9A, which resulted in scores of 3 and 13 respectively. These scores do indicate a need for a brief intervention. Both scores do, actually, and may even suggest the need for referral to treatment. And that was further clarified during the brief intervention. So we're going to pick up the role play after that brief intervention has been conducted, and it's time now to talk about how the girl may need some more services. So I'll start out. Okay, based on what we've discussed, I am concerned about the amount you are drinking and about your opioid use. Given the level of your use, it is important for your well-being as well as your mental health that you go to a substance abuse treatment program for further evaluation. You may not know this, but opioid and alcohol use often make the depression worse. This is very common and it does concern me. Kind of like what I said before, 1 in 3 who struggle with substance use also suffer from depression. So what are your thoughts about all of this?
More treatment? Well, it took me a while just to finally come here.
I know it's a lot, but it's important that we come up with a plan that can work for you. I want to see if we can come to some agreement. The problem is we don't have the staff here with the expertise to conduct a full diagnostic assessment and to follow up that assessment with possible treatment for substance use and co-occurring problems such as depression. So you can see why I'm thinking it would be helpful to bring on board a referral for more assessment. But let me ask you this. What supports do you have that might help you to attend treatment?
Well, I'm coming here for my depression. My parents have been pretty supportive of that, but they're also pretty angry at me right now. But they're pretty angry at me for my alcohol and my drug use. But I guess I suppose I could, ask them to help me with this too. But I really am not sure about all this. This all seems like pretty intense to me.
I can understand that. It's okay to have concerns like this, and I can help you address them as we move along. And I agree with you. It would be good to seek your parents' support. It also might help you to begin to repair your relationship with them at the same time, as well as how they can maybe help going forward with this current problem. As I've said, I think there's a problem here that needs more attention by additional professionals. What about this? Can I set up an appointment at the Substance Use Disorder Treatment Center for a diagnostic evaluation? And they can see more about the issues and see how they might help you. What do you think of that?
Yeah, I think that would be easier for me. I really don't like talking on the phone.
Great. Okay. I think we can go forward with that. And let's figure out a plan how we can invite your parents to also join in this conversation so we can talk about the plan going forward and help support you while you set up this important appointment. They can help perhaps facilitate that appointment. Would that be okay?
Yeah, that sounds good. Okay.
Tracy, thank you for the help with that. So I thought one of the interesting angles on this role play was the practitioner trying to figure out how to involve the parent or parents. Now, it's an 18-year-old who in many states would be legal to seek services without parental consent, but it's likely the practitioner found out something during the brief intervention that suggests that there still is enough relationship between the girl and the parents to help facilitate the girl getting help. And in a practical standpoint, the practitioner could have gotten agreement with the adolescent about, okay, can we have a phone call right now? We can do that while we're all together. We can put the phone on speaker phone so everyone can hear it, and the practitioner could help connect the teenager and even work out what could be said. So the parents are on board, and the parents can also help in any way to facilitate the professional referral. There are a few more issues to address in this section of the webinar. I turn to the topic of barriers to seeking treatment. A SAMHSA survey found that most often reported reason for not receiving treatment is not being able to afford it. 37% responded in that way in that survey. Among individuals 18 and older, 9% feared that seeking treatment would negatively impact their jobs. So all of us, I think, are aware of various barriers when discussing treatment options. And it's important that you do what you can to appease realistic barriers that are facing the adolescent and the adolescent's family. If the adolescent simply is not interested in treatment at this time, rather than push her or him and jeopardize future opportunities, it's important for the practitioner to accept and respect that decision in a non-judgmental manner. He or she may be more willing to accept the notion of treatment during future sessions or at some time later if they know you're not being aggressive with this issue. A follow-up conversation with the reluctant adolescent, and perhaps including the parent, can be essential if you want to try to move that initial conversation towards a more productive outcome. But when there is a referral to another health professional, behavioral health practitioner, or a treatment program, there are several steps you can take to facilitate a successful link. Consider a four-way discussion involving you, the practitioner, the adolescent, parent or parents, as appropriate, and the receiving treatment program or provider. Try to do this immediately after the adolescent consents to treatment. The purpose of this four-way call or discussion is to inform the treatment staff or practitioner of the adolescent substance use, treatment barriers, or ambivalence, to agree on whether the program or some other treatment option is best, to gain support from this receiving program to solve or remove some of the treatment barriers, and to schedule an appointment. As noted earlier, it is important to have a discussion within a short period of time when gaining the adolescent's agreement for a referral. After that, no-show rates climb steeply. One data set indicates after 14 days, about 50% of clients will not show for treatment, regardless of their motivation. Making a referral that adolescents do not successfully follow wastes their time and the practitioners. It is essential that the practitioner in the treatment program or provider be able to share information and share responsibility for helping the adolescent. Use a release of information form to facilitate this. Make sure your form complies with state and federal substance use, medical record confidentiality laws, and with the Health Insurance Portability and Accountability Act, or I think as most of us know, HIPAA. To facilitate quick communication between professionals, use a client update report so everyone involved can stay informed of the adolescent's progress, status, and additional needs. In the appendix of the Learner's Guide to Adolescent SBIRT, there are sample release information and sample client update report forms. As noted earlier, you have to try to take an active role in the referral process. Below are some more detailed tips of what you can do to make sure referral to a care provider is successful. The first, locate a knowledgeable program provider. It is not common for an adolescent or young adult to have a primary physician. If the adolescent does not already have a relationship with a qualified physician who is knowledgeable about addiction medicine or adolescent behavioral problems, perhaps you can recommend one. It is a good idea for you to have developed a list of addiction-focused physicians, counselors, and other specialists in your community who can provide needed services for your adolescent. The more familiar you are with these services, the more smoothly you can make your handoff. Second point, send a written report. Maintain consistent communication with the adolescent's physician so any concerns that arise during a session with the practitioner can be addressed by that receiving service. Significant clinical issues encountered or addressed by either the practitioner or the service need to be included in the adolescent's records. Making the release of information mutual allows you and that receiving service to communicate back to the practitioner on the adolescent's progress so that everyone is up to date on how things are going. Third point, make it look like a report, but be brief. Many clinicians and physicians are quite busy, so it is important that the written report be brief, concise, and official. A report should include the date, the adolescent's name and date of birth, the practitioner's contact information, and any relevant information that needs to be conveyed to the counselor or physician so they can remain informed. It's best to think about your update report to not be any longer than one page, because if longer, it's probably not going to be read. A fourth point, keep the tone neutral. The practitioner can provide brief detail about the adolescent's use or abuse of substances. Avoid direct recommendations about prescribing medications, as doing so could be practicing beyond the scope of your license or credentials. In some ways, just provide the facts. Here is a list of video resources regarding the process of referral to treatment. There are excellent resources from Boston University's BNI-Art Institute, which has 4 videos. Then there's SBIRT Oregon and the University of Florida Institute for Child Health Policy in Cherokee National Behavioral Health. The last section of this webinar will address follow-up and support issues. If there is no referral to treatment, discuss with the adolescent that you, the practitioner, would like to follow up to see how he or she is progressing, even if the goals did not include cutting down on use or abstaining. But if there is a referral to treatment, have a discussion about what to expect from additional treatment. Adolescents and adults generally do not know what to expect from a more specialized counseling experience. If appropriate, the practitioner can also follow up with adolescents who are getting these additional services. When a follow-up such as this is presented to the adolescent as the standard of care, and it is what you do with all adolescents and young adults, it is likely you will get agreement from the adolescent. How would this follow-up look? Consider reconnecting with the adolescent after a couple weeks to see if she or he got what they needed from the meeting or counseling sessions. Ask how things are going and check in to see if any additional services are needed. If you find that your client has slipped, treat this type of relapse or lapse as an opportunity to engage in additional or different services rather than couch it as a failure. One could think about two relatively similar but somewhat distinct types of follow-ups, and they're distinguishable mainly by how soon they occur after the session and the amount of information they collect. The two we will discuss are booster and linkage follow-up, and the second type, recovery management follow-up. A booster and linkage follow-up is a model that has been shown to be effective by use of a brief telephone call within a few days or weeks to the adolescent who just received the brief intervention. Doing so can dramatically reduce alcohol intake, unhealthy drinking patterns, and other important outcomes. This type of linkage or follow-up reinforces the action plan made, demonstrates the practitioner's concern for the adolescent's health and well-being, and gives both an opportunity to resolve barriers or ambivalence through additional brief intervention. A telephone-type booster follow-up also gives the practitioner an opportunity to re-administer any screening tools, such as the CRAFT or the audit, or other screening tools, to assess change in substance use since the last interaction. Then there is the recovery management follow-up. This type of follow-up generally occurs several months after the last interaction with the adolescent. These are primary linkage connections that give the practitioner and adolescent opportunities to assess whether issues have been resolved, assess need and motivational for additional treatment or services and resources, and to reinforce changes that have been made since the first contact. This type of follow-up also provides an opportunity to measure change and gather feedback for improving the practitioner's services for the adolescent. One suggestion: try these on a quarterly or 6-month basis after the last time you have met with the adolescent. And of course, you can do more than one. Both types of these follow-up contacts can be conducted with a phone connection. These kind of phone contacts should be brief, generally not more than 15 to 20 minutes, and should always utilize motivational interviewing techniques outlined earlier in Webinar 3 of this 4-part series, or detailed in Module 5 of the Learner's Guide. Some features to consider when making a phone contact. First, consider texting the adolescent to set up the phone meeting. phone conversation may begin with a brief, casual conversation as a way to get acquainted. The practitioner could also remind the adolescent that they had told him or her they had planned to do this type of follow-up. The goal of the call is to help adolescents solve the problems for which they initially contacted you and to link adolescents to supports and services that they may need now before they experience any additional problems. Time now for our third audience polling question. Please select your answer on your device, and we'll talk about it in a minute. So here's the question. To what extent have you used phone contact with adolescent clients for post-treatment follow-up to see how they are progressing? To what extent have you used this method? So please choose one of the four options. All or nearly all of my clients, some of my clients, a few of my clients, or not at all. Okay, distribution of answers, kind of roughly equal across the four, although a little disappointing. The number that's the largest is in the not at all answer, 34%. So about a third of you haven't. And then there's a range of using it from 17% all or nearly all to a quarter of you, either some or a few. Hopefully you'll consider this is a really helpful tool. And with the digital age we live in and with the teenagers' ease of the telephone, I think it's something to put into your repertoire and have it as a common tool in your clinical toolbox. Some suggested ways to conduct a phone conversation. Hi, put name of the adolescent. This is, put your name. I am following up on the conversation we had on, insert a date. This will only take a few minutes. Is this a good time to talk? So if yes, continue. But if you get a no, you could offer this. Okay, that's not a problem. We can schedule an appointment to talk another time. I'm available, provide some days and times. So which day and time would work best for you? Confidentiality is an essential element of any outreach to an adolescent. If you do a phone call follow-up and you get a voicemail, here is a suggestion. Hello, this message is for, insert adolescent's name. This is your name. I'd like to take a few minutes to speak with you. Please call me, provide work number, between the hours of, provide the time. If I don't hear from you, I will try again later on, and provide a date. If you reach the adolescent, but she or he does not agree to a time and does not want to talk right then, the practitioner might say, I understand how hard it is to find a good time. Do you have any questions about why I'm calling? Wait for a response, see what you get, then proceed with, okay, I'll go ahead and leave my number with you. I look forward to talking with you soon. This concludes the formal presentation of the webinar on issues pertaining to referral to treatment. In sum, I think you can appreciate that the referral to treatment process can be challenging. And perhaps it's the most difficult part of the screening, brief intervention, and referral to treatment model. Yet it is a vital component. Many youth who are receiving a brief intervention will need more services. and need more counseling than what a brief intervention can provide. And you can play a vital role in facilitating more care when needed. Thank you for your attention, and now back to Tracy, our webinar host.
Well, thank you, Dr. Winters. I appreciate you sharing all of your expertise today and learning more about different referral options and way to approach the conversation using motivational interviewing. And so we're really grateful to you for being our presenter. In the last few minutes together, I'd like just to remind you that for future reference, you can download the PowerPoint slides and other resources from our website at sbirt.webs.com/referring-adolescents. Now, after this webinar concludes, you're going to receive a follow-up email from us, and that's going to, again, contain the instructions for watching it on demand, as well as obtaining a free certificate of attendance, and also information about how to complete this very short evaluation survey. Now, again, we would really appreciate you completing that survey because it really does help us assess how we're doing and really to better understand your needs. So, in addition, I would also like to offer you, if you have questions about SBIRT implementation, evaluation, training, anything related to these webinar series or any of the work that we do, you're welcome to schedule a free telephonic technical assistance session by emailing me at mcpherson-tracy@norc.org or reaching out to the SBIRT team at sbirtteam@norc.org. And last but not least, I just want to thank all of you for attending and staying with us today. And I will conclude today's webinar and hope that you have a wonderful rest of the day. Thank you.